Any other questions? Okay, let's move on. Doug, we're going to share a little bit about care integration and payment reform.
So it's always great to follow Dr. Grundy because he set the stage in terms of thinking about the big things that have to happen. And in the last year, the governor's task force was responsible for creating a roadmap that in fact would figure out how do you make these big three things happen. We start from the perspective that in Minnesota, at least, the Minnesota model that is centered around not-for-profit health insurance companies and health care that is delivered by one of the most robust primary care workforces in the country, as well as a delivery system that's characterized by a number of integrated delivery systems, has achieved over the years remarkably good health at a relatively low cost. That is, if you look at measures of health in Minnesota, we generally have been among the healthiest in the country while spending the lowest percentage of our gross domestic product on health care. However, that doesn't mean that health care has been affordable. And the increasing cost of health care has taken a significant toll on the middle class. So the spending increases that have occurred in health care, as well as the need to think about how we're going to devote money to education and infrastructure, in fact, also create challenges for the state government. As well as we have done in Minnesota, in 2010, we spent about $38 billion on health care, and the projection is that by 2020, we will have a health care spending level of about $80 billion. Now, when we think about what are the drivers, remember that 5% of the population consumes 50% of the costs. And this is where we then think about care integration. Because for those patients, the most important thing that we can do is to invest in the workforce and the infrastructure that would facilitate the integration of care, especially that complex care. That's where the money is. Now, over a year's time in the work of the task force and a subgroup that I led on care integration and payment reform, we worked to consider how we would try to put together practice reform, payment reform, and benefit reform all at the same time. In the end, the roadmap actually has 8 basic strategies. And of those, many of them are ones that physicians in particular and other healthcare providers will have an important role in sustaining and in shaping. So some of these actually do need to be created for the future. The very first strategy that we identified is the need to pay for value. We then considered that the next important strategy was to support patient-centered and coordinated care, building on the medical home model that Minnesota legislated in the 2008 reform. Our third strategy was to prepare and support the health provider workforce, and there were a number of specific elements in that that were actually developed by the workforce subgroup. That subgroup actually was chaired by Dr. Zink, and I think she perhaps has talked to the Academy on a number of occasions about a number of recommendations that came from that group. The fourth strategy was to improve health for specific at-risk populations. So in terms of addressing significant disparities, there are a number of strategic elements that we have included in the roadmap for this problem. Next is to engage communities. So when we think about the outcomes of health, and remember that health is really expressed as the ability to maintain role functioning. So when you talk to people around the state, they express health as being able to do the things that I have to do so that the people who depend on me are going to be okay. So it doesn't mean I'm free of disease. It means that I can function and function well. And that's a really important concept, because when you then start thinking about what you want to buy, and I was really intrigued by Paul's comments about what IBM wants to buy. When I'm thinking about buying health for Mayo Clinic and my employees, I want them to be able to come to work and function as a great employee. I want them to go home and function as a great parent or a spouse or a mentor. And right now, we actually don't have any measures in the system that say to people who are providing care or supplying care, that's what I expect you to provide. So we actually did cover this a bit in some of the discussions at the Reform Task Force. Another part of engaging communities is that we would consider in the state of Minnesota authorizing 10 pilot projects that would look for communities that would be willing to do a complete integration of health care, primary care, behavioral care, social services, and other community services. And to help facilitate that, the state has applied for an implementation grant from CMMI that would provide the necessary funds to support that kind of integration. The sixth strategy was to measure performance and ensure system stability. So there was great concern expressed to us as we went through our deliberations about the impact of these major changes that are coming. What is the risk that as we move to concepts like total cost of care, that we will totally disrupt all of the effort that we have put into medical home? What is the risk that the influence of total cost of care contracting will force massive consolidation of systems and disrupt the care, especially that depends on smaller practices in rural Minnesota as well as in some of the urban locations in the Twin Cities? So we spent a fair amount of time thinking about how you actually will measure the impact of the changes and then be prepared to deal with the consequences. Next, the seventh strategy was to design benefits to enhance personal responsibility. So we heard about that discussion earlier. That actually goes a little bit beyond what Manny had mentioned in terms of the essential benefits set. So there's a set of design considerations that we have to think about how we're going to implement, and whether that is going to be the exchange that will do that, or whether that will be a regulatory responsibility of the Department of Health or of Commerce or wherever. Manny's the expert on that. That's what we got to do. And the last was that we have to be able to increase access and support consumer navigation. So we have to really find ways that we can help people make good choices, and the choices that will then be effective for them. So when you look at those strategies, in reality, when you think about the involvement of physicians, physicians are specifically involved in at least 6 of those 8 strategies. Now there's some details that are in some of them. For example, one of the details is that when you think about this transition, there are a number of physician practices that will not be prepared for total cost of care implementation. The big systems have lots of resources, but they only account for about half the delivery capacity in the state. So one of the specific recommendations we have is that the state should make investments to provide technical support and other resources for smaller practices as they evolve toward this concept of total cost of care. And in the implementation grant, the budget that we developed actually asked or considered spending at least $6 million for that kind of support. Depending on where we look at the budget, maybe a little more in a couple of places, but at least $6 million. So I will tell you that at the work group and at the task force, there was very significant concern that we continue to make the necessary investments, especially in primary care, that have been one of the major reasons for the success of Minnesota, and which we know will be one of the foundations of success in the future. Now we're a little concerned because if you look at some measures of health in Minnesota, we're beginning to see some sliding. So we need to begin to reverse that. So we are also thinking about how we articulate the goals for health and the goals for spending that allow us to achieve better health at a more affordable rate, at a more affordable cost, I should say. Although at one time we had some very specific recommendations about how we would do that, we have left that now conceptually to another one of Manny's favorite configurations, a public-private partnership. But the idea is that that group will have about a year, maybe a little longer, to say what do we want to accomplish in terms of health, and what do we think is affordable, and how much do we think we can afford to spend. And that we would use the guidance of that group then to figure out where we want to be and measure against that performance over the next 3 years. Now, if we can't do that, then somebody's going to have to, so presumably it would default to the government but we didn't make a final decision about that. So in a few short minutes, that summarizes actually about a year of fairly hard work. You should recognize that you have an important role. If you haven't thought about it here, when we talk about things like engaging communities, you need to begin to think of your role as a leader. So we have a mayor of a community, a formerly elected mayor, but I would suggest that every one of you in your role as a leader in the community should think of yourself in essence as the mayor of the community or mayor of healthcare. As physicians, from my personal perspective, we should actually lead our communities in the decisions about what we want for health and how we can get there in an affordable way. And when I listen to some of the discussions around the state at particular meetings where there were physicians present, I saw lots of citizens actually seeking the guidance of physicians. So this is another great opportunity. It is not going to be codified in statute. It probably won't even be represented in some of the recommendations that might come from future groups. But I think it's an important role for us as physicians, and I hope the Academy and all of you individually will take it to heart and run with it. So I'm going to stop there and see if there are any specific questions or comments.
Thank you. How many of you have read this report? It's called The Roadmap to a Healthier Minnesota. It's about 4 or about 6 in the group. How many of the rest of you on the panel? You've all read it. Okay, good. It's a very, very interesting document, and I commend you on really turning out a very useful document on focusing the state for the future of creating a healthier Minnesota. The question I have, and you almost addressed that at the end, this is a very comprehensive report, many good ideas in it. Have you thought about how you can leverage that to bring about change rather than just issuing the report?
We had a number of discussions about how we might be able to do that. There are many, many opportunities. We obviously would benefit greatly from the leadership of physicians. We would benefit greatly from the active participation of citizens in terms of co-creating the future. And in between the active participation of businesses, both small and large, legislators and other groups. We have in Minnesota rich resources. I mean, from the perspective of care integration and thinking about how we would organize care, there's the Institute for Clinical Systems Integration. We have organizations like MAFP. A few years ago, the MMA took a great leadership role in terms of Healthy Minnesota. I'm personally hoping that at this juncture, the MMA and the MAFP and others will step up and perhaps take that lead and facilitate that discussion and co-creation. In some of the work that we're doing in the Center for Innovation at Mayo, I hope we can take some of the results of those experiments and learnings and share them across the state that might help a number of practices who are confronting some of these things more rapidly adapt to the new environment. We're a pretty resource-rich state, and we have a pretty strong commitment as a state to sustaining health. So I hope that we can maintain that common spirit and move forward and not become fragmented as has occurred too generally in Washington. The Minnesota model, personally, I'm biased. I think the Minnesota model is the model that the country should have followed rather than the Massachusetts model. But we're a long way from the major media markets, so that's where we struggle. Maybe it's like baseball, I don't know.
Yeah, it'd be nice to see some organization do some pilot projects implementing some of these.